for what promises to be an engaging and informative event. Today, we will delve into the critical discussions surrounding the recent resurgence of measles cases in Delaware and across the United States. We are honored to have Dr. Stephen Eppes as our speaker. Dr. Eppes specializes in pediatric infectious diseases at ChristianaCare Health System. He serves as the Director of Pediatric Infectious Diseases and Associate Infection Prevention Officer for ChristianaCare. Throughout his career, Dr. Eppes has been recognized for his clinical and teaching skills, receiving numerous teaching awards from pediatric residents. Dr. Eppes is also co-chair of the Immunization Coalition of Delaware. We look forward to Dr. Eppes' insight and expertise on this important topic. Thank you for being here, Steve, and let's make the most of our time together. Welcome, Dr. Stephen Eppes.
Why, thank you, Steve. I'm pretty sure this is the third time I've done a measles update for the Medical Society of Delaware over the years. Every time measles rears its ugly head, there's a lot of interest in it. I'm happy to do this, and hopefully we'll share some information that will be of use to everyone. Whenever I discuss measles, I think back to one of my mentors who's pictured here, Dr. Sam Katz. Sam was instrumental in the development of the measles vaccine, the very vaccine we use today. He worked in the lab of Dr. John Enders in Boston back in the late 50s and early 1960s, and we owe him a debt of gratitude for the vaccine that is so important to prevent this terrible disease. As mentioned, no disclosures, and these are our objectives. So let me first go over the last case of measles that we had at ChristianaCare. It happened to be an adult because I think this is illustrative. Woman, no significant past medical history. She presented to the emergency department with chief complaints of fever, rash, and cough. She had previously been seen in one of our medical aid units, and there she was tested for flu and was negative, and she was empirically treated for flu with oseltamivir. The fever, it turns out, had developed about 5 days previously, pretty high fever, and then a rash that began on the face and neck and spread downwards, with some GI symptoms as well. She had a very important travel history, which was the travel to Singapore and Bali, both places that are under immunized, and she had just returned 12 days previously. Her physical exam showed that she was febrile, tachycardic. On her HENT exam, she had small white spots on her buccal mucosa bilaterally, which of course were the complex spots. Subsequently developed conjunctival injection and then rash on the neck, chest, abdomen, back, buttocks, and upper extremities. In the emergency department, she had some tests done and had mildly elevated transaminases, a chest x-ray, which was negative. And I'm so happy that somebody thought to get the measles serology. It was one of our adult infectious disease doctors, as a matter of fact, and her IgM was positive, confirming the diagnosis. Thankfully, she herself made an uneventful recovery. And because people had been thinking about the diagnosis and masked her in triage, and because all of the employees were immune, there were no secondary cases. That's what we like. So there's a map of the globe showing the most indigenous areas in the world for measles. In the pre-vaccination era, as you may know, virtually everybody got measles, and there were an estimated 2 to 3 million fatalities a year. So it's not just a rash and fever, it's a potentially fatal illness. WHO tries to keep track, but they estimate that only about 1 in 10 cases are reported from these countries, which often have underdeveloped health infrastructures, but they're pretty good about tracking deaths. And we know that in that one calendar year of 2022, there are 136,000 deaths. What's very troubling is measles in Europe. In the year 2022, there were under 1,000 reported cases in the WHO's European region, but between September of 23 and August of 24, there were over 138,000 confirmed cases. So it's really spread like wildfire throughout most of Europe, as you can see there on the map. In Europe, all ages have been affected. There have been 21,000 hospitalizations and deaths, up to 5 deaths in that 1 year period of time. And this was all a result of reduction in measles immunity due to a reduction in measles vaccination because of the COVID-19 pandemic. So it hit hard in Europe, but it's affected us as well. As a result, the immunization rate went from 96%, which is enough to stem a measles outbreak, to 93%, which will allow for measles to have ongoing transmission. It's estimated that 1.8 million young children in Europe are unimmunized. And in UK, which we think of as having a very well developed health infrastructure, only 85% of kids starting school have had both their shots. Well, here's what happened in the United States with the pandemic. So when it hit in March of 2020, our immunization rates went way down. You see that for kids under 24 months in the dark blue and greater than 24 months in the light blue. As a result of that, the CDC sent out this reminder that, yes, of course, we're in a pandemic and everybody has to be respectful of that. But please, please, everybody who's responsible for vaccinating children, try to get them in and get them vaccinated, or we're going to have a real problem. And you may remember that just before our pandemic, in the fall of 2019, we had one of the worst measles epidemics in this country in memory. I'll show you a bit more about that later. So we were very worried that measles was going to make a resurgence, just what you don't need when you have a coronavirus pandemic as well. So our immunization rates recovered, but they still have not gotten to pre-pandemic levels. In the United States, between 2020 and 2022, 61 million doses of MMR were either delayed or missed entirely. And for school year 2022-2023, only 93% of children in kindergarten had received both their doses, which was also down. So I'm going to show you 2024 because I think it's a nice prelude to what we'll be talking about for the next 15 or 20 minutes. So 2024, we had 284 measles cases. I'm quite surprised that it was not higher, but this involved kids under 5, as you can see, kids 5 to 19. So the majority were kids, but a good many were adults as well. And the vast majority were either not vaccinated or unknown vaccination. A handful had 1 MMR dose, and even fewer had 2 MMR doses. 40% of these people were hospitalized. So here's how it happens, and this is an infographic from CDC from 2024. If we have a non-immune traveler, and that could be somebody who's not been vaccinated, or that could be somebody who was vaccinated but just didn't mount an immune response, they go to an endemic country, they get exposed, they bring it back with them on the airplane, and then what happens when they arrive back in the United States? Well, it shows you on the left that if they land in a population that's pretty well immunized, there's not going to be much of an outbreak, maybe a case or two. If they come back to a community that's under-vaccinated, then you may see a small to medium outbreak. But if they come back to a closed-knit and unvaccinated or under-vaccinated community, which is what happened in Illinois in 2024, you're going to get a large outbreak. So let's go back in time and then come back to the present and show you what's going on in 2025. So this graph shows you in the bad old days before the first vaccine was licensed, the number of cases that we would have every year. So over 500,000 reported cases, but not all cases got reported. So it's estimated that 3 to 4 million cases occurred each year, and there were about 500 deaths. And then when the first vaccine was licensed and utilized in the community, there was an amazing 99% reduction in the number of cases of measles. But unfortunately, there was a resurgence in 1989, 1991, where we had a lot of cases of measles. And a lot of that, and I'll show you in a moment, involved Philadelphia. So that's when the second dose of MMR vaccine was recommended in 1989. And as a result of that, our immunization rates were excellent and our immunity was excellent. And the number of cases diminished to a point that measles was declared eliminated in the United States in 2020. Now, eliminated does not equal eradicated. Smallpox is eradicated. Poliovirus 2 and 3 are eradicated. But elimination means that there's no endemic measles transmission for the preceding 12 months. So in Philadelphia, during that period of time, 1990, 1991, there were 1,400 cases of measles and 6 deaths, mostly in children and 35% of these were from two fundamentalist churches in Philadelphia who did not vaccinate. But let's come up to the post-elimination era. So after the year 2000, and see what's happened. So the first major occurrence in this country was in Ohio in the largely unimmunized Amish population, amounting to 23 outbreaks and 667 cases. The Disneyland outbreak, I think most people are familiar with. Somebody from the Philippines brought measles to the theme park, and a lot of people who were unimmunized got measles, carried it back to their own home communities, and there were little measles outbreaks across the country. The Minnesota outbreak started with the undervaccinated Somali population, and I think this is fascinating. The Somalis were having a lot of autism in their children, and they brought this to public health authorities' attention, and virtually nothing was done about it. But anti-vaxxers got wind of this. They went to the Somali elders and said, "You know why you're having so much autism? It's because you're giving your kids MMR vaccine." And they stopped doing MMR vaccine on a routine basis, and there was an outbreak that occurred as a result. Then in 2018 and 2019, we had multiple outbreaks across New York and New Jersey, mostly in unimmunized or underimmunized Orthodox Jewish communities. And that was well over 1,000. That risked us losing our elimination status. It went beyond New York and New Jersey, though, to all the states that you see there. Delaware had none, but our neighboring states of New Jersey, Maryland, and Pennsylvania did. So this is from your local epidemiologist. This is a free service. You can easily Google it and sign up. I find it very useful. And YLE shows us that here we are in 2025 with the number of cases that I'm going to go over with you that are already rivaling the 2018-29 outbreaks that we had in the United States. Mm-hmm. So here's the steep Epi curve that you see there, much steeper than what we had in 2024 or 2023. And as of March 20th, just a few days ago, there were 378 cases in the calendar year 2025. 321 of these have occurred in Texas, New Mexico, and Oklahoma. Children have been the hardest hit population, but adults have been affected as well. 38 people have been hospitalized. 2 deaths have occurred, 1 child in Texas and 1 adult in New Mexico. The largest outbreak has been in Gaines County, Texas, and I'll show you why in a moment. And Texas officials don't think this is going to come under control anytime soon. The map there shows other areas in the United States that are affected, mostly single digits outside of Texas, New Mexico, and Oklahoma. So this was in the New York Times just a few days ago that officials in Texas fear it's likely to persist for a year, maybe longer, perhaps making us lose our elimination status. Some physicians are saying in interviews that they've given up hope that a vaccination campaign would end the outbreak because mandates are deeply unpopular in Texas. So the vaccination effort has been a real struggle. I just discovered this website today, as a matter of fact. This is Yale, and you're welcome to go on it. It's real easy to find. And they're keeping us up to date on the outbreak situation in almost real-time basis. So I think this is important on an epidemiologic basis, but also instructing us all how important it is to maintain a 95% immunization threshold or immunity threshold, because we know that that's the number of people in the community it takes to be immune to prevent an outbreak from occurring. And you can see that a couple of those counties are much lower than 95%, Gaines County being the lowest at just under 83%. I saw something, was a school superintendent from Gaines County that was issuing T-shirts. And on the T-shirt, it said, least immunized school in Texas. And the immunization rates in this one particular school were down about 15%. So they were actually celebrating their low immunization rates. But that's what's happened. That's why there's so many cases in Gaines County. Now, there's a large Mennonite community there, and that's partly, I think, the issue. But a lot of people who don't have religious convictions are not getting immunized as well. This is the timeline. I'm not going to go over in detail, but just to show you that the first case was January 29th, and it spread like wildfire, with the 2 deaths occurring at the times of those black dots that you see on the timeline. These are the immunization rates among the people who were affected in Texas, New Mexico, and Oklahoma. Very few had gotten 2 doses. Most had gotten no vaccine at all or were unknown. This map shows the measles vaccination rates for kindergartners across the country, and you can see darker green is better, of course. And some people may be surprised that places like West Virginia and Alabama, Mississippi have very high rates. But that's because those states eliminated their non-medical exemptions for immunization years ago. So they have high immunization rates. In Delaware, for kindergartners, it's about 94%. So just a little below the 95% threshold that we want to achieve. So here's some basic epidemiology. I think it's important for clinicians to understand this. This is a highly infectious agent. It is the most infectious virus that we now have in the United States or around the world. If someone is infected and exposes a population of non-immune people, 9 out of 10 will become infected, 90% attack rate. And we know that you have to have at least a 95% immunity in the community to stop ongoing transmission. As I mentioned, it was nearly universal in the pre-vaccine era, and it typically affected preschool and school-age kids. In the post-vaccine era, it's been a little bit different. Now, leaving aside the current outbreak, most infections occurred in kids 6 to 12 months. Now, why would that be? Well, up to 6 months, babies will have some protective antibody acquired from their mom transplacentally, and then at 12 months, of course, is when they start getting their vaccine. So that was a very vulnerable time period. So here's just an infographic showing what I just told you, that 9 out of 10 people who lack immunity are going to be infected if they are exposed to an infected person. And 1 out of 5 who get measles will be hospitalized. The incubation period averages 10 to 12 days. So that's for the time exposure to the time of the prodrome. The prodrome lasts usually 3 or 4 days. So it's 14 days from exposure to the onset of the rash. Infected people are contagious 4 days prior to the rash onset. The transmission is airborne with virus remaining viable in air samples up to 2 hours. These are tiny little droplets that remain in the air, and they can, as they're suspended in the air, they can go down the hall and around the corner and into another room depending on airflow. So the clinical features are that it's a prodrome of high fever and malaise, and then the 3 C's that we learned in medical school, which stands for cough, coryza, and conjunctivitis. Right at the end of the prodrome is when you get the Koplik spots, which are little gray-white lesions on the buccal mucosa. People liken them to grains of salt or grains of sand, and they occur just prior to the rash. They're very transient. Now, I've seen my share of measles. I've never seen Koplik spots because I always seem to get called after the rash develops. So that's what they look like if you're lucky enough to see them. They're very transient, only last 12 to 24 hours. The rash is very characteristic. It begins after the prodrome, usually on the 3rd or 4th day of illness, and it's morbilliform, which means measles. It's erythematous maculopapular, begins on the face near the hairline, and then spreads downward and outward. And as it spreads, the previously affected areas of skin may develop confluent erythema. So this is from a famous infectious disease textbook, and it just shows you what you would expect on the first day of rash. You may still see the Koplik spots, and you see discrete little lesions. By the 3rd day of rash, it's spreading down and out, and previously affected areas like the face are becoming more confluent. So here's some pictures. Here's a little girl who is probably on day 2, 3, maybe 4 of rash, with her weepy eyes, with the conjunctival injection, and the miserable look that these children have. Here's measles on day 4, so well established, going down the body, face is confluent. Similar situation here. And there's a close-up of what the measles lesions look like. So here's a scheme showing the time frame, what you can expect during a measles case after exposure. So the incubation period, 10 to 14 days. Then you develop the prodrome, the exanthem, and then recovery. People are most contagious for a few days prior to the prodrome till the rash resolves. Why do we worry about measles? Because of the complications. These are the common complications that are, medically important, but usually not life-threatening. So otitis media is extremely common, bronchopneumonia, croup, and diarrhea. The more severe complications are here on the right. Acute encephalitis, about 1 in 1,000, and this can result in permanent brain damage. Death, either due to respiratory or neurologic complications, 1 to 2 out of 1,000. Now, what I think is interesting is that in the Texas, New Mexico, and Oklahoma outbreak, we've already had 2 deaths, but only a little over 300 cases reported. What does that tell me? Well, either that we're really unlucky to have that many deaths with over 300 cases, or that it's being underreported, which I think is much more likely the case. So probably lots more out there to get a death rate of 2 deaths. So who knows? We could have over 1,000 cases, but not being diagnosed or reported. And then there's this late occurring condition called SSPE that develops years after recovery from measles because the measles virus has stayed in the central nervous system and it causes a fatal degenerative central nervous system disease. I've seen only 1 case of that, and it is dreadful. So people at highest risk for complications include young infants and children, adults over 20, pregnant women, people who are immune compromised, and people who are vitamin A deficient, which is almost exclusively in other countries. If you are immunocompromised, you may have an altered disease presentation. The rash may be absent or look different, much higher risk of complications and a fatal outcome. And these people also will have a prolonged excretion of virus. So not like I showed you on that timeline, but they can excrete for much longer. And additionally, they do not respond very well to vaccination. So this came out from the CDC in early 2024 when we were having a smattering of cases. And we had some in the Delaware Valley, one who actually made it to Delaware. So I show this because what was said in this COCA alert is just as true now as it was in early 2024. And your most important diagnostic tool is a good history and physical examination. Good old history and physical exam. So you want to take a good travel history. You want to take an immunization history, an exposure history, and then you want to do your good physical exam and look in the eyes, look at the ears, find out how the rash started, how it's progressed. It is very characteristic. I think a physician who is around with measles or maybe an infectious disease physician is not going to make the mistake very often just because it's so characteristic. And then the 5 keys here on this COCA call, this COCA alert, were isolate, notify, test, manage, and vaccinate. So isolate, that means if you're suspecting this patient has measles, slap a mask on them and put them in a room as quickly as possible. And if you have an airborne isolation room, that's ideal. Notify, that would be notify your hospital infection control or infection prevention department. If you don't have one, or if you're not in a hospital environment, notify your public health authorities. Test the patient, and that's usually going to be a PCR on a nasopharyngeal or buccal swab, and the measles-specific IgM. Manage means manage that patient and manage the close contacts, and vaccinate, vaccinate, vaccinate. You can vaccinate for post-exposure prophylaxis and vaccinate everybody in your community. So this came out from CDC also in 2024, and this is guidance for healthcare facilities. So if it's somebody who has signs or symptoms of measles, you can provide instructions on what to do on arrival. And it's okay to say, stay in your car, and somebody will come out and evaluate you without you having to come in to the medical facility. I've done that many times for chickenpox. So it's a legitimate way to approach it. If they have to come in the medical facility, then tell them which entrance to use, tell the staff what precautions to take, and then, like I said, put a face mask on the patient as quickly as possible, separate them from other patients, don't let them sit in a waiting room, get them into an individual room as quickly as possible, preferably if you have it, an airborne isolation room. Limit the transport of patients within the hospital. Put a mask on them if you have to take them for x-ray or somewhere else in the hospital, and do that as quickly and efficiently as possible. This is what airborne precautions involves. So standard precautions means hand washing. And then for us healthcare personnel, it's either going to be an N95 mask, which you see on the bottom right, or a PAPR, which you see on the bottom left of that little infographic. Remember that the virus can remain infectious in air up to 2 hours. So that if somebody has been in the room and you think it might have been measles, that room needs to be vacated for 2 hours and then appropriately cleaned. This came out from last year, and I put that up there because the phone numbers are just the same as they were a year ago, and DPH really wants you to contact them if you think you have a case of measles. This is a sentinel event for public health. So there you see the daytime business hours and then night and weekends business hours. So I have to put this up for a couple of reasons, because this was bad advice. It came out from the Florida Surgeon General in February, where they were having an outbreak of measles in school-aged kids in Broward County. And this Surgeon General, who's a bright, well-trained man, but a very bad Surgeon General, said, and this went out to the citizens of Florida, said it's normally recommended that children stay home until the end of the infectious period, which in this case was March 7th. As the epidemiologic investigation continues, this date could change. However, due to the high immunity rate in the community, and it wasn't high, it was in the low 90s, as well as the burden on families and the educational cost of healthy children missing school, the Department of Health is deferring to parents or guardians to make decisions about school attendance. This was absolutely the wrong thing to do. It flies in the face of everything we've learned about measles and everything we've done on a public health basis to try to keep measles outbreak from occurring. And I also show this because this individual, Dr. Lopato, is being thought about as the director of our CDC. How do you make the diagnosis of measles? Well, as I said already, it's a history and physical exam to start with. And then to confirm the diagnosis, you can do measles viral RNA by PCR, serum, nasopharyngeal or throat, and urine. You can use all three, which gives you the highest yield, but by far the most important is the respiratory sample, which can be either nasopharynx or throat. And then, of course, you want to get a measles-specific IgM. The IgG test is not useful clinically, but is really for demonstrating immunity. So remember, nasopharyngeal or throat PCR and measles-specific IgM on serum. So here's what we have here at Christiana Hospital, just showing the order set. So it's the IgM and the PCR. It's very important to use the right equipment. So our Delaware State Lab wants to receive it in viral transport media, which you see there on the bottom right, and they want you to use a Dacron or flock swab. They will accept other specimens, and they'll run the test, but they're going to put a caveat on the report that this was not ideal in terms of the specimen collection. So this is how you want to do it correctly. If you're at a hospital that's not ChristianaCare, you probably want to look on your own hospital's laboratory website, or perhaps they've issued an alert of some sort to guide you. Treatment of measles is supportive. If you're in a resource-poor country, vitamin A is recommended. Vitamin A is also recommended for any severely ill patient, particularly children. This virus is susceptible in vitro to the antiviral agent ribavirin, and that has been used on a compassionate basis for treatment of severely ill patients, but there's never been a controlled trial and is not FDA approved. Well, what about vitamin A? So our Secretary of DHHS, RFK Jr., came out with a statement shortly after the TNMO outbreak got started and said, well, you can just use vitamin A. Well, that's bad advice. Vitamin A does not prevent measles. It may help in certain selected cases, but giving high doses may be dangerous. And I'm thinking about when President Trump in his first term mentioned bleach, and people were admitted to emergency departments because they were taking it literally and they were ingesting bleach. And I'm afraid that people are probably taking RFK Jr. seriously and literally and ingesting large amounts of vitamin A, but that can be dangerous. So the best advice on vitamin A actually came from a consensus statement that was prepared from the National Foundation of Infectious Disease uh, Summit. And basically what they say, and the arrow is mine just for emphasis, is that vitamin A should really be prescribed for pediatric patients, not adult patients, with a confirmed measles diagnosis. And there you have the doses. So not mega doses, but supplemental doses of vitamin A. So the rest of my lecture is going to involve preventive efforts. So prevention in a healthcare facility involves appropriate isolation, care of exposed persons, post-exposure prophylaxis to those who've been exposed, outbreak control, which is isolation for infected people, and quarantine for exposed people, and immunization. Immunization is the cornerstone of measles prevention. So we have two FDA approved and recommended measles vaccines. They are MMR, which is measles, mumps, and rubella, and MMRV, which also contains varicella. These are live viral vaccines. They do contain other things that you see there. They're very safe and very well tolerated, but you should be aware that there are some adverse effects. First of all, MMR is a live vaccine, so you can get viral replication after you've given an intramuscular dose, and that can lead to a mild measles case. So low-grade fever after 6 to 12 days, a transient rash, down around 5% of individuals. They are not considered contagious. Back in the days when I practiced general pediatrics, which was a long time ago, I would always warn people that this could happen, so you don't freak out and go to the emergency room or call me back. That's just part of MMR vaccine. Much more rarely, you can get febrile seizures. That is not related to MMR in particular. It's related to the fever that some people get. But you can see there it's very uncommon. And thrombocytopenia tends to be very transient, can also occur. But MMR and MMRV vaccines are very effective. After one dose, it's 93% effective for measles. Now, I want to just make the point that unlike mumps and unlike pertussis, we don't have a problem of waning immunity with measles vaccine. It's a primary vaccine non-response. So that's why we learned in the outbreak in 1989, 1990, that if you give a second dose of vaccine, you get an additional 4% people protected. So that's why we should give 2 doses to all children. If you have natural measles, you're, as I did, you're considered immune for the rest of your life. There are some precautions for MMR vaccine. They're listed on the left. There are only a handful of contraindications. We don't want to give it in pregnant women or in women who may get pregnant 3 months after their MMR vaccine because it's a live viral vaccine. And we particularly worry about the rubella component because, as you know, that could cause congenital rubella syndrome. Extremely rare with vaccine, but it is considered a contraindication. Anybody who's had a previous severe allergic reaction, that's a contraindication. People who are severely immunocompromised, and I'll use the example of HIV AIDS. If your CD4 count is less than 200, that's considered immune compromise sufficient that you would not want to use measles or MMR vaccine. And then if you've had another live vaccine within the past 4 weeks, why is that? Because measles is temporarily, and measles vaccine are temporarily immunocompromising, so that you may not have a good response to those vaccines. So just a bit about this, because this has also been in the news recently. How do you deal with vaccine skeptical parents or vaccine skeptical patients or vaccine skeptical communities? Well, first of all, you have to realize that this is not uncommon at all. Because of vaccine skepticism, close to 1% of US toddlers have had no immunization. And when we have an outbreak, it's often initiated or sustained by unimmunized kids. It also is worth reminding you that school requirements vary by state and personal belief exemptions vary by state. And unfortunately, as a result of COVID and the COVID vaccine um, skepticism, that's also carried over into other vaccines as well. So this is a cartoon, but I think it's illustrative of what's going on out there. I had no idea measles was so dangerous. It's almost like making life or death decisions about my child's healthcare based on a Facebook video is a bad idea. This is not a cartoon. This was an actual quote from the Natural Health Anti-Vaxxers Community Network. My 3-year-old is not vaccinated, and there's currently a measles outbreak in my state. Any suggestions for precautions I can take to protect her would be very much appreciated. You can't make that up. But I think our message is that vaccines cause adults. All vaccines are FDA in this country are FDA approved and CDC recommended because they are safe and effective. And if we didn't have them, many, many children would be dying as children and never reach adulthood. So winding up with some information about travel. So CDC, and that's where this comes from, this infographic. CDC is very worried that we're going to have non-immune United States citizens travel to other countries, get measles, and bring it back and spread it within their communities, as I showed you toward the beginning. This is from Delaware, DPH. It just came out a few years ago, telling us all here in Delaware how to make sure travelers are up to date on their MMR vaccinations. This came out earlier in March from CDC, this health advisory, basically giving us travel guidance, knowing that a lot of people are going to travel at spring break time and during summer vacations, and how to make sure they can travel safely and not bring a lot of measles back to this country. So here's what's in that hand alert. I'm not going to read it to you. That's very small font. You can look it up and read it for yourself, but I will tell you that these are the salient points. So if it's an infant under a year, but over 6 months of age, who's traveling or who's in an outbreak situation, you can give them MMR vaccine. It doesn't count against their 2 doses that they have to receive to be considered immune later in childhood, but you can protect them between 6 and 11 months of age. And I think we should all be doing that for travelers or, God forbid, we have an outbreak. If it's a child 12 months or older, they need to have 2 doses of MMR separated by 28 days. If it's a teenager or an adult doesn't have evidence of immunity, it's 2 doses of MMR separated by 28 days. Now, many of us are considered immune. If you've had 2 doses of measles vaccine, either in MMR or MMRV, you are considered immune. If you have a positive measles IgG titer at any time, you are considered immune. If you had physician-diagnosed measles illness, contemporaneously documented, so you can't say, well, I had measles, in 1959 and I'm immune. No, it has to be your doctor had to see you and document that you had classic measles illness. If it's somebody born before 1957, they're considered immune because almost everybody got measles who was born before 1957, but we cannot use that criterion for healthcare workers. And if it's anybody, an adult who's received 1 vaccine who's not high risk, and high risk is international travelers, college students, and healthcare workers, they can be considered immune. So this is an interesting paper that came out some years back, just showing what the level of immunity was in the United States in 2009 and 2010. And it's probably not as good as it was then, because a lot of the people born before 1957 have now died, and our immunization rates are a little bit lower. But at this point in time, measles immunity in the United States was 92%. And like I say, it's probably across the board a little bit lower than that right now, which is why we have to worry about measles spreading in our community. So when the measles outbreak in New York and New Jersey was getting started back in 2019, CDC sent out this Dear Provider letter, and these points are just as true now as they were then. We don't need to actively screen adult patients for measles immunity if we're in a non-outbreak situation. Now, if I was a practitioner in Gaines County, Texas, I might like to know my measles titer, but for the vast majority of adults, they don't need to be screened for measles immunity. If the patient is traveling internationally and immunity is unknown, you don't need to test them for immunity, just vaccinate them with a dose of MMR vaccine. For healthcare personnel, everybody should have evidence of immunity. Anybody who's non-immune, who are exposed, will need to get post-exposure prophylaxis with MMR vaccine and would need to be excluded from work from day 5 to day 21 after exposure. And good advice for all healthcare providers is make sure you keep your vaccination records. MMR is pretty darn effective for post-exposure prophylaxis. So if somebody's been exposed in the last 72 hours, you can give the vaccine, and it actually provides about 83% protection. And it can be used as post-exposure prophylaxis in kids as young as 6 months of age. If you're not eligible to get MMR vaccine for some reason, you could get the measles immune globulin within 6 days or IVIG. The problem with measles immune globulin is that there's a national shortage and it's very hard to get. The last time we had to get some for an individual in Delaware, which had to do with hepatitis A exposure. There's somebody in Delaware back 7 or 8 years ago. It took a week to get the immune serum globulin, so it's not useful if you have to wait this long. I just contacted our ChristianaCare pharmacy yesterday and asked what the situation was. They think they can get it faster than that, so I'm hopeful that we would be able to get it if we, God forbid, have measles in Delaware. So this is my concluding slide. It's a little infographic from Delaware's DPH, just getting the word out to the public that measles isn't just a rash, but it can cause pretty serious disease, and we all need to work our best to not have a measles outbreak in Delaware, and that involves the community as well as all of us healthcare providers. So Lynn, that is my slides, but I see that we've got close to a quarter of an hour left for comments, questions, and discussion.
Yes, thanks, Steve. That was an excellent presentation. Lynn, if you'll help me with the chat, are there any questions there?
Sure, we do have a question. Given the recent decline in vaccination rates and the surge in measles cases, how long would it take for a significant portion of the unvaccinated population to develop natural immunity through widespread infection, similar to pre-1957 era? Considering the potentially lengthy time frame and severe health consequences of such a scenario, do you believe this information alone would be compelling enough to convince vaccine hesitant individuals to vaccinate? If not, what additional strategies or messaging might be effective in emphasizing the urgency maintaining high vaccination rates in light of the current measles resurgence?
Well, that's a multi-part question comment, but whoever wrote that is brilliant. But I will answer the first part of the question first. I think it would take a long time to develop, to let enough people get measles that we would have natural immunity in the population. That's never going to occur because we already have what I showed you on that study. 92% of the population in the United States or so is immune. So you're never going to have enough widespread measles, natural measles, to get the population that immune. Now, RFK Jr. used that strategy in American Samoa some years back, and that actually was disastrous. and we had, I think, 80,000 cases and a whole bunch of deaths as a result of the strategy of trying to get people naturally immune to measles. So I don't think we want to let that happen. So the next part of the question had to do with, if we can't do that, what about the vaccine strategy? Unfortunately, you got to get people to get vaccinated to get the community immunity up. And as I showed you that New York Times article, quoting some health officials from Texas, that may take a long time, unfortunately, because of vaccine skepticism and people resisting vaccine mandates. So it's a tough situation, and I don't think there's an easy answer. I think if we're looking at Delaware, it's going to be a minor outbreak if one has ever occurs at all. And I say that because of the natural immunity that's already out there. And if 92% of Delaware is immune, 94% of kindergartners are immune, it's not going to be a big outbreak. So it's hit Pennsylvania, it's hit New Jersey, it's hit Maryland, and we're only talking about a handful of cases in each situation. So I don't think it would get much more than that, unless there's a pocket of unimmunized people in Delaware to whom measles virus is introduced. And I'm aware, of course, that we have an Amish community in Kent County that had a problem with pertussis twice in the last decade and a half. So, for those people and for people who can't be immunized, I think we all have to be concerned.
Thank you, Dr. Eppes. And are there any updates, or what are your thoughts on booster doses?
So you wouldn't have, so we give booster doses if there is waning immunity, like for pertussis, and like mumps if we had a mumps outbreak. But it's really primary vaccine failure that occurs after the first dose. Remember, I showed you 93% would be immune. So it's to give that second dose gets you up to 97%. There is no recommendation for a third dose of MMR vaccine to prevent measles. There is to prevent mumps. If we were to have a mumps outbreak, which is defined as at least 3 cases in a community, then it is recommended to give MMR to prevent to people who are eligible to prevent worsening of a mumps outbreak. And the question, all right, here maybe I'm reading between the lines of that question. So a lot of people are asking, do I, need a shot if I even if I satisfy one of the criterion that I showed you that showed what constitutes immunity? And so the answer is currently no. Nope. Nobody else will need a third dose of measles vaccine. Or if you've only received one, you're adult, and you've only received one in a non-outbreak setting, you still don't need another vaccine, according to current recommendations.
Steve, in the office, I'm getting a barrage of phone calls that are coming in about measles titers. And I get a sense from what you're telling us tonight that that's not really a recommended thing to do. But boy, it's a hardcore press when your patients are calling and saying, I want that titer. So I get a titer on a patient who's 64 years old, and her measles titer is low. I send her to the pharmacy for a measles vaccine, or she finds herself there, and the pharmacist says, I'm not going to give you that until you get a note from your doctor that says, because this is a live vaccine, and kind of gave pushback to her. It's one of my notes that I have to call her tonight. What shall I tell her?
Well, Steve, when you say low, do you mean undetectable or low?
No, it was low. Let's say I don't remember the call here. Let's say if it was 15, it was like an 8 for the measles. The mumps and the rubella were fine, but the measles titer was low.
I think if she has any antibody, she's probably immune.
Okay.
So, but let's just take your question and say if it was a negative titer, had no immunity. I hear your comment and I feel your pain. I can only imagine, how much trouble that's going to be for you and every other practitioner. But I'm not going to tell you something that goes against public health advice from CDC and DPH, which is that if they have any of those criteria of immunity, so MMR vaccine, positive titer at any level really, or physician documented measles, you probably don't need to do a titer. and just hold pat. And that's going to take some reassurance, I realize, but you're not the first person that's brought that question up. So good question, very legitimate, but I would try to reassure that patient.
Okay, very good.
We had a comment from Dr. Commons that you gave a superb presentation, and he thanked you for your presentation. Another question, given the recent surge in measles cases, has there ever been research comparing the effectiveness of educating people about the specific negative outcomes of not vaccinating against measles versus simply promoting vaccination?
Well, I think they're part and parcel of the same thing. I think, obviously, it takes a few minutes of the busy practitioner's time to do that, but in terms of counseling for the importance of vaccination, we have to say, what if you don't get vaccinated? The CDC a few years ago developed a nice little tool that you can download from their website that shows how to advise people who have not been vaccinated or not had their child vaccinated. And, it says, avoid this and avoid that and be careful and hand washing and so forth. But the best solution, of course, is to get vaccinated.
Thank you. That's all the questions we have in the chat.
And if that's the case, we're going to let Dr. Eppes off the hook tonight a little early. Thank you so much, Steve. Very important.
Steve is excellent as always. So, and Steve, you're excellent as always, and
thanks, Stuart.
Never boring.
Well, it's a subject matter that's not boring. That helps, right?
Well, even when it's a subject that may be boring, you make it interesting.
All right. Well, thank you.
He is indeed the man. Thank you, Steve, for joining us tonight. An excellent presentation. And instructions again to claim your CME will be posted. Have a good night, everybody. Be safe. Enjoy spring that's coming very shortly.
Good night,
everyone. Thank you again.
Thank you. Thank you, Dr. Eppes. Thank you, Dr. Kushner.
Goodbye.